Welcome to the classes of epidemiology. In the details on the randomized controlled trials, we are going to devote this entire session. I have already told that randomized controlled trials or RCT is the heart of the modern research work. And we have also talked about some steps which are required to be taken for this RCT. First of all, we need to decide the population which is suitable for our study. I had given the example of say population may be entire universe to a small village or a small area or a particular group of the women or particular old age people, whatever it is. But the population means a homogeneous population. When we are talking about old age people, we are talking about old age persons in entire city. So that is a suitable reference population for us. From that, we need to have a target population. Suppose there are 10,000 old age persons in city of Ahmedabad. I want to study which old person should be selected. For example, should we select 45 plus, 50 plus, 60 plus, 60 or 70 plus, only men, women, or those who are having some morbidity, comorbidity, otherwise, say that particular reference population should be narrowed down to the target population because we want to study specifically for a given cause related factor. So everything has not to be included. We need to find out which will be the particular group out of that specific population which will be helpful to come to the conclusions. That's one thing. Once we have decided that, then we have to have a sample. There are sampling techniques in the statistics. You will learn it, or perhaps you have some knowledge about it, but we can identify a random sample, a proportion of the sample, which is required to study based on the experiences or sometimes based on the expectations. Suppose we go for the 10% of the total population for this sampling. Say, let us continue that example of the old age persons. We decide that 60 plus old age individuals will be included, 80 plus will be excluded. In the group of 61 to 80 years, there are about 10,000 old age persons in Ahmedabad city. And I have decided to take 10% of them, say 1,000 individuals for the study. Now these 1,000 have to be randomly selected. Randomly selected means all 10,000 old persons have a chance to appear in that sample. That is randomization. Once we do that randomized suitable, then necessary exclusion. Sometimes what we need, some people who are very sick may not have to be included into the study because generally these studies will continue for some time, maybe months or years, depending upon the type of this study. So we will exclude them. Suppose I am doing a study of the for the cause of the cancer. The person himself is having a cancer, then there is no fun of taking that individual into this. Those who are not having the cancer will be subjected to inclusion. Similarly, I am to give a drug for the diabetics. Now, those who do not have diabetes, they are not the subjects for me because they cannot be tried for that, isn't it? So, necessary exclusion should be done. Some persons may not give the consent to be included into the study. Remember, please, that in cohort study or specifically in the RCT, randomized control study, the person who is being studied is important human being. His consent after explaining everything to him that these are the risks, this is what we want to do, the benefit of the study will be like that. Once he gives consent, informed consent, thereafter only we can include him. Suppose somebody doesn't give the consent, he has a freedom to be away from the study. So some people will not be included in the study because of their conditions. Some people will not be included in the study because they do not provide the consent. They do not agree to go with that. After that only the randomization should take place. Once we start with the randomization, we will out of those 1,000 individuals, because we have taken that figure as an example, 1,000 individuals, we will part two groups, 500 or 500. 500 will be included for the experiment. Suppose I am going to give those old persons a good food, good high calorie food, and find out the outcome. Other old people will not be given that high calorie food. Or suppose we want to give those old people certain drug, certain a particular drug, and that drug will not be given to the other group. So experimental group and control group. This will be identified. Both these groups will be subjected to manipulation. In a way, the experimental group will be given the drug, while that other group will not be given the drug. So somehow the drug is the only thing which is different between these two groups. That's why whatever happens to the experimental group is because of the drug per se. That can be concluded by and large. After due study, we can come to such a conclusion. And once we have started the manipulation, once we have started the implementation or intervention, we should go to follow them up after 1 week, 2 weeks, 1 month, 2 months, 3 months, so on, till the expected outcome. Suppose the drug is for the diabetes and we are treating those persons who are having diabetes. 500 are given those drugs, 500 are not given those drugs. After 6 months, we will see what is the level of the blood glucose or what is the level of the glucose tolerance test, whatever parameters we decide, that will be tested after 6 months, again after 1 year. And suppose we want to conclude the study at the end of the 1 year, that will be the time when due analysis will lead us to the inference that what has been the effect of that particular drug in controlling or deteriorating the condition of the diabetes mellitus in both these groups, the control group and the experimental. This is the just and design for the randomized control study. Let us focus on the protocol. What do we mean by the protocol? That is the first step. Protocol is a document. It mentions the aims and objectives of the study very precisely. It also asks the questions: will this drug help bringing down the blood glucose level of the patients to the expected level, say 10% reduction, 20% reduction, whatever? That question has to be asked. It is expected that while answering this question, we will have the entire study targeted to that. So research question will be asked. And the same benefit will not be available to the control group. Suppose that does not happen to them, then the drug will be found responsible. Then criteria for the study: which old persons will be included, why they will be included and others will not. So criteria for the population, criteria for the inclusion, criteria for the exclusion from the study, and what if we don't do the control population? Who will be taken for the control population? Most of the times we randomizedly identify the control as well as the experimental group from the same population, because that allows us to have a single blind study. Then sample size is to be identified in the protocol. Protocol is a document which gives you all guidelines till the end of the study, maybe after 2 years, 3 years, but sample size initially it is written in the protocol. Procedure for allocation: who will be given the drug, who will not be given the drug. Again, who will give the drug, who will not give the drug, how much drug, how frequently it will be given, everything has been decided beforehand. The treatments, which treatment is to be given, if they are on any other treatment, should be they excluded or included. So details of the identification of the subjects, details of the maneuvering which we are doing or intervention which we are doing have to be read. Sometimes we have to identify the specific operative procedures. When the blood sugar should be taken, when we follow them up, morning samples, evening samples, or both the samples, how frequently, every week, fortnightly, monthly, with what particular equipment we will test it, or will it be computerized, how that test will be done, who will perform the test, are the performers are already trained for that, everything has to be identified. The specific operative procedures will also to be written down. Everything must be written down. Who will be responsible for conducting this? Who will fund it? How much fund will be provided? At what period the funds will be available? Who should be the staff to carry it out? Who will be hiring the staff? What should be the qualification of the staff? All these details make a protocol. And once that is done, and this will be very useful, suppose the study is conducted into several centers. Say one population is taken from Rajkot, another from Ahmedabad, third from Vadodara, fourth from Surat, fifth from Banaskantha. All centers have the same protocol, and the same protocol has to be preserved and acted upon till the study is completed. That's a must. And once we do, the sources of errors will be reduced. There will be minimum subjective bias once we do it. If necessity arises, after preparing the protocol, one should run a pilot test. Some of these persons, or some of such persons, may be tested with our questionnaire or with our test laboratory test. Whether we will be able to do that, that will talk about the feasibility. Will it be completed in time? Because what we are thinking may not be in practice possible. We have taken 1,000 persons from different areas, and it is not difficult to, it is not possible to access them so frequently. That's why the feasibility study or the pilot study or the preliminary run up can also be arranged for that. And this will allow us to fill in any flaw. Suppose there is any mistake, some error, that will be taken care of. Once this protocol is defined, it gives everything, all guidelines are given in that. Then we go for first selecting the population, reference population and experimental population. Reference or target population means where the results are to be applied. Suppose I am taking those 1,000 individuals in Ahmedabad city, it is clear that what suppose that drug is for the diabetes mellitus is to be given, that will be tested in that particular population itself when this study will be over. Provided the drug is identified as a beneficial one, we will apply it there. That's the population. Okay. Once that has been done, once so then experimental, which is the group out of that population of the old people, who will be included 1,000 out of 1,000, 100, 500, 200. That experimental group has to be identified. It is derived from the same population. See, that's a small group which is now being subjected to study. And ideally, there has to be random selection. Sometimes it is very difficult, but it should be carried out randomly. Randomization is very important. All those included must be subjected to informed consent. That's a must. They should be representative of the population. They are not different from the entire population. Say, they should be as normal as the norms of the population. And they should be eligible for this study. I have given the example that a person who is not having diabetes cannot be tested for the diabetes mellitus drug, isn't it? He cannot be taken. Say, suppose I am doing a vaccine trial, but the person is already having that, suppose diphtheria vaccine is to be tried, and the person had already had diphtheria in the past. He cannot be included. He has already experience of the diphtheria. Such exclusions have to be identified. I have talked so much about the randomization, but it requires little more because the study and non-study group both have to be randomized. Suppose out of 1,000 we have taken 100. Those 100 individuals who are to be studied and those 100 individuals who are not to be studied, both of them are better randomized without any other process. Once it is done, then selection bias will be removed. This will remove the elimination bias or selection bias. Matching can be done by the subgroups. Say, suppose out of 100, 50% are males, 50% are females. Age group, 50 are in 61 to 65 group, 20%, 65, 6 to 70, these many persons, 71 to 75. Similar persons in the control group, similar persons in the experimental group. So on we can go for subgroup matching. Randomization is done once they are entering the study. Before that, say identification, etc., it's okay. But once they start doing study, then only after qualified for the trial and given their informed consent, then only the randomization is possible. If they are not given the consent, there is no issue of randomizing them. Okay, so randomized experimental and randomized control groups are now ready. Now we do the manipulation or intervention. Now for this intervention, either we give something or we withdraw something. We had talked about that last time. The details had been given. Either we can provide some facility or withdraw the facility. That also will give some result. And that outcome has to be thought about, that this will perhaps happen. And suspected factors should be identified. Suppose we are thinking about, say, providing iron tablet, and Then thinking about that anemia will be improving in the adolescent girls. One thing is that you are giving it to the experimental group, but not giving to the non-experimental or control group. Here you are supplementing something. But suppose another group is there that you are saying that you do not take a particular substance in your food, like say iodized salt is not to be used by them, and other persons are using that. So that either withdrawal or the addition of a particular substance which is under study is very important for the manipulation, and which which becomes a dependent variable. So what happens? Both the groups are similar, and I am giving the drug. Drug is an independent variable for changing the situation. And what comes out, say I have given iron tablet, it is an independent variable. Happening of the reduction of the anemia is the dependent variable. If the drug is effective, it will reduce. If it is not effective, it will not reduce. Which is dependent? The anemia is dependent. Independent is the drug. And that's why it becomes an independent variable. Once this is done, again repeating, manipulation or intervention is done, follow-up has to be arranged, and follow-up has to be at the defined intervals of the time. It is written in the protocol when we are going to follow up in a standard manner. If BP is to be taken, which blood pressure measurement instrument is to be used, whether mercury or other or digital, whatever you are deciding. But it has to be in specified manner. Equal intensity. Suppose you are measuring every week, then it has to be every week till the study is complete. It's not that in beginning you are taking every week and later on you are taking every month. No, that's not allowed. And with the same given circumstances, the person should be continuously in the same circumstances. This is very important because the circumstances change. Suppose there is something else which has disturbed the entire family, then the situation may be acting on our study. That should not happen. And ideally, in a study, the circumstances continue to be the same till the final assessment of the outcome is done. The results are available to us. And duration of that trial, it depends whether it is short or long on the based on the expectation of the significant outcome. What is going to happen? We have some idea that okay, we are measuring for anemia. After 1 year, the results will be wonderful, or after 2 years, it will be more or better to depend upon. So that expectation gives us the duration of the period. Now, during this study, whether it is for 1 year or 2 years, certain losses are always expected. Either somebody may die, someone may be migrating, or someone may lose the interest and withdraws his consent. That is possible. And that's why from the very beginning we should think that the such attrition or losing of the person is minimized. That's very important. Last but not the least is the assessment. We continued the study, we did it, and then we are assessing for two things. Either the results are positive, say a drug is actually reducing the level of diabetes, this is a positive result, and the mortality is reduced, that is also good, or the cost compared to the earlier drugs, cost is less. These all are the benefits. Compared to that, the negative results will also be there. How much cost? Suppose the cost of the study is much more than the cost which has been reduced because of the treatment. That's also possible. Sometimes the side effects of the drugs may occur. Sometimes the adverse effects may lead to the death. So those negative results are also very important. We have to balance the positive results and negative results versus the cost which will be saved now and which cost which have already incurred. Assessment is once done for the positive and negative factors. They should be subjected to the statistical analysis, whether it is significant or not. Some difference may be just minor, but if the difference is significant, we should go ahead. That yes, drug is not good or good. That final decision can be taken based on the results. Now, in this entire study, what we are afraid of is the bias. Some errors are happening and we should try to avoid it. It may not be possible to avoid entirely, but we may try. One is the bias on the part of the participants. Some participants are joining because they are very healthy or in a very good shape. And they say, okay, I will join it. But if they do not fit with the criteria of the study, they may avoid them. And sometimes there is a subjective feeling. Okay, I am taking drugs, so it will be better. Say that's a positive feeling. So what we will be doing, that we will be telling that you may receive the drug or you may not receive the drug, because randomizedly we may select them. That's the second issue. Observer bias. If I know that this person is receiving the drug, I may be positively noting down his results. Sometimes it happens. It's a human being. Ultimately, we are human beings and we are guided by some feelings also. So that should be avoided. And third one, a favorable report somebody may prepare for the entire study. The report is favorable because he thinks that subjectively everything was good. To avoid these biases, there is a blinding process, and we will end up with that. One is single blind. What happens here, that the participant doesn't know whether he is given the treatment or he is given a placebo or a simple tablet. He doesn't know. So randomly we are distributing amongst those. All are diabetics, but the treatment for the diabetes is received by 50%, and they do not know who is getting that particular treatment. The tablets are of the same type, shape, etc., etc. Nobody can differentiate. That is single blind study. Person does not know what he is taking. Double blind studies are mostly conducted. Most of the studies are double blind, where the person who takes the treatment, he does not know. Similarly, the investigator also does not know that who is given what tablet. And that's why he will be unbiased for measuring every time. Frequently, when he follows up, he doesn't have an idea whether the person is receiving the placebo or the tablet. And last but not least, the triple blind. The person taking the drug does not know, the person investigating does not know, and the person who is analyzing also does not know who is taking the treatment, so that it is entirely flawless. This is this ideal platform for the randomized controlled trials. We have to talk about several examples of the randomized controlled trial and some non-randomized controlled trial, because most every time we may not have to go with the randomized controlled trial because the nature may not allow for that. And that's why we will discuss both these randomized controlled trials examples and non-randomized controlled trials whenever that is applicable. So we meet next time.